I think since all of us were together last week, unless folks feel like introductions would be useful again, we can perhaps jump right in on our task here. So again, as Amy was outlining, I'm a facilitator here as a representative of Duke Margolis, and so I'm not providing my personal opinion, just helping kind of facilitate the conversation, take the notes, and keep us on time. And the goal of the breakouts today is to really get your reactions to the updated draft principles and provide an opportunity to think about some how those principles can translate into strategies and strategies for increasing healthcare coverage, and then saving some time to talk about kind of what would be useful next steps. So I'll share my screen here in a minute so we can work on the principles together. We will, after this, go back to the full group and then do the report out. So Chip was very kind to do the job of reporting out for us last week. Does anybody else want to take on that task this week?
Wow, really?
Chip did such a great job last time. I would nominate him to repeat.
Dr. Newton's membership dues are going up this year.
Help if I have to, Chip, but I think you did good too. You handle it.
Is that all right with you, Chip?
Yeah.
Okay. Great. And then let's see, I'm trying to think if there's anything else I needed to touch on before we dig in here. Yeah, just to reiterate that these principles are close to being finalized. So the goal is to, make sure that if there's anything else that you would like to add or change before they're finalized, and then that process of kind of what are some additional strategies that could fall under these principles, specifics related to behavioral health or telehealth or patient health plans, tax credits, that nature. So with that, let me go ahead and share my screen. Can you all see that okay?
Yes.
Okay. You can make it bigger too if that makes it any easier. I tried to highlight some of the changes in yellow just from last week, so kind of where they are. As Amy mentioned, the first two were sort of condensed under this maximize healthcare coverage with affordable, quality, and comprehensive healthcare coverage. This bullet around program simplicity, enhancing the health of North Carolina, and then some additional considerations were added based on the conversation. So are there other, any additional thoughts in terms of finalizing what's represented here? Anything you would add or tweak?
Just Representative Cunningham, as I was looking at the principles, they all seem to be, on point and inclusive on what we're trying to do. I really think they look pretty good.
Last week we talked a lot about how important it was that this piece around affordable, quality, and comprehensive healthcare coverage kind of went together, because it we spent a fair amount of time talking about coverage in and of itself is not the solution if it's not affordable and high quality, comprehensive.
Representative Cunningham, last time we talked extensively about kind of all these principles being important, but prioritizing some of them. And I like the way these were condensed, because this really puts a focus on number one. Mm-hmm. But is there any other prioritization that you or the group would think about that we would want to really highlight, other than that first principle kind of being the capstone?
I see what you're saying. I guess we would have to look at all of them. I know that first one is one of that is a priority. It has to have all of those entities to work. Affordable, quality, comprehensive healthcare coverage. That's what we're trying to get to. Can you scroll down?
Sure.
Okay. I guess, Chip, when you look at the health system sustainability, that's huge, right there. Is the health system sustainability, especially rural areas.
That would be the one piece I'd suggest we consider modifying, is adding the word rural into health system sustainability. I think that's what most of us think about when we think about this.
Yeah, I think so.
It was interesting in that conversation from Thorpe in Georgia that they had not anticipated the rural impact, considering how rural the state is. I thought that was a little odd.
Yeah, and I thought just for them to pick up just 52,000 people, and then when I was like looking at the demographics, where are these 52,000 people? They were still very close to, metropolitan or more larger urban spaces.
Right.
Okay.
So does this addition capture, you think, what you were saying, Dr. Moncad?
Sure.
Can I add something as well?
Yes.
Or a comment at least? Being an independent primary care provider, knowing particularly in rural areas that independent healthcare providers are an important aspect of the rural community. A lot of times when we talk about healthcare system, people usually assume that to mean the hospital systems. So can we somehow, and it's important for a practice like mine, for Clinton and Sampson County to be viable. So can we somehow clarify that maybe?
I think we could definitely add, independent providers in there as you're talking about, but there's also the other way is to flip the title. Instead of saying health system sustainability, you can say systems of health sustainability.
You can also put providers, those providers, independent providers,
right. Or health system and independent provider sustainability.
That's fine. I just think it's important to be mentioned there.
Yeah.
And I know, Dr. Newton, how much physicians like to be called out as independent physicians. So I appreciate the providers there, so we could capture our independent mental health providers as well, since we've talked about how that integrated support is so important here.
Agreed.
So if we go down to, reducing the disparities, solutions to increase healthcare coverage should prioritize reducing disparities by geography, by race and ethnicity. It's when you start talking about disparities, I think it needs to be identified as healthcare disparities. Is identified as healthcare disparities. Since we're very focused on the health, I think it should be identified. Other disparities is not probably going to be our focus.
What do others think they're specifying healthcare disparities?
Yeah.
Yes, I agree with her. I agree.
My only flag is in, I think one of the presentations, maybe in the second session, there was some indication about how with improved health access, that improves people's all the other non-healthcare related things, their financial status and a variety of other things. So maybe among or chiefly healthcare disparities, but part of it is to make sure that people don't go into financial ruin if they get a cancer diagnosis or something like that.
Yeah, that falls up on the additional considerations for access, lowering the cost of care, support and access to primary care, and social deterrence. So the social deterrence kind of come up under where the healthcare disparities is. That's how, how we identify them in the healthcare profession, is that the social deterrence impact the healthcare disparities.
Potentially maybe adding disparities into the additional considerations. Maybe is that what you're?
Well, you may want to do it there, because that does fall within that same category. One goes with the other. The social determinants of health and healthcare disparities. Healthcare disparities are impacted by the social determinants of health. Determinants of health. Mm-hmm.
Would you want to consider reducing health and related disparities? Does that take the focus off that you're trying to achieve by putting health in that title, or does that include the things that Emma's bringing up?
When we talk about, I'm on that minority health. When we talk about healthcare disparities and minority health, we also lump it into underserved communities. So it go hand in hand. I don't know. Let's think about it. But I know the focus, we're not going to fix all of those other things that come up under there. You know what I'm saying? I was just trying to stay focused on what our focus is on reducing health disparities. There are numerous other disparities in the community.
Mm-hmm.
Yeah, I agree. And I agree with you that really saying healthcare disparities is important for the focus of this particular council. But I also agree that obviously this is if you reduce the healthcare disparities, that is sort of a foundational piece for reducing the other disparities, as you mentioned. So anyway, I agree with using healthcare, and you can say and related would be all right, but I think if we're trying to focus it, let's just focus it on healthcare.
Thank you, Tom. Okay.
So the other piece in here that looks to me like a thing rather than a benefit would be the next one on behavioral health, expanding coverage there, right? So if we kind of prioritize the maximization of access at the beginning, health system and independent provider sustainability, reducing health disparities, and increasing access and coverage to behavioral health services, wouldn't the effects of those four things be a better use of taxpayer dollars, strengthening of our rural communities, supporting our business community? I guess I realize those things are principles that we want to call out because they're considerations, but it seems like those four things really kind of encompass the do this and you'll get these other things that we consider really important.
And the four you mentioned, sorry, Chip, was rural, efficient use of taxpayer dollars.
The very first one, the maximizing on the previous page.
Oh, okay.
The top one.
Maximizing.
That this is sort of the intervention, and the others kind of fall.
Yeah. I guess I'm asking that question. Because as we're sitting here talking about prioritization, it seems like one good way to introduce it to the larger group would be to say, we think if we prioritize these 4 or 5 things out of all these priorities, we think we will knock out the other principles simultaneously.
I see what you're saying.
Yeah, so if we prioritize maximizing healthcare, health system and independent provider sustainability, reducing health disparities, and increase behavioral health services, increase access and coverage of behavioral health, then I say that, and then doing those 4 things would not create program simplicity. So I'm kind of negating myself here as I'm saying this, but trying to come up with a way to put a focus in on these things. Otherwise, we're just adopting kind of everybody's best thoughts. And we've all kind of agreed to these in various formats in other places, and trying to figure out a way to suggest to the larger group that we have to hone in some way, you know?
I'm gonna go back to the behavioral health. You know, when we say maximize healthcare coverage, what kind of healthcare coverage, right? So we're saying affordable, quality, comprehensive. You know, one of the aspects with behavioral health, physical health, they're still separated, even though we've been trying to integrate it and do it together for it to be comprehensive. We're trying to do that now, but we still are self-identifying physical health from behavioral health, but it should be integrated. So I was looking at the maximize the healthcare coverage. When we're talking about maximize healthcare coverage, that's physical and behavior. And even with the substance abuse disorders, we're not just trying to target the physical aspect of it.
So are you suggesting that between comprehensive and health that we should put physical and mental, or?
I'm wondering if we need to identify, because one of the things we know for certain right now is that parity for behavior health is not actually doing what it's supposed to do. We got statute for it, but they've done studies and they're showing that, you know, it's really not working, the parity that's supposed to be in place. And that's probably why our behavior health, well, of course, our behavior health already was in crisis before the COVID, and now it's going to be way much elevated after COVID, whenever that ends.
Yeah, I think your point is well taken, Representative Cunningham. And it looks like Rebecca's pointing out that comprehensive health care coverage is defined in this.
Okay, I see it down there. I can see it. It's a little bitty, but I can see it now.
Yeah.
Okay.
Well, that's why I need to put 2 pairs of glasses on to be able to read it, right?
Well, I got 2 on, some contacts and some readers.
But I can try and capture your point here too, Representative Cunningham, just to say that, you know, this should also involve like enforcing current or existing parity laws.
Parity laws, yeah.
If that seems to capture. What you're saying. And Chip, sorry, I want to make sure I captured the previous point you were making here before we move too far. So prioritizing maximizing healthcare coverage with, what was it, provider sustainability, efficient use of
health
taxpayer dollars,
disparities, and behavioral health.
Sun is bothering me.
And these were the priorities that the others will, like, if we emphasize those, the other pieces will sort of indirectly.
Well, I'm trying to figure out if we can get to that. I don't know if everyone agrees with that premise, because I was saying that I kind of contradicted myself with the very next one being program simplicity, and doing those 4 things is not going to make the program simpler. You know, so just doing those would not automatically do it. But I guess maybe just the idea of, out of these principles, we still have to pick out, to Representative Cunningham's points last time, what are we going to do first? What are we going to do second? What are we going to do third? You know, if we do these things, this will start the domino or the chain of these other things
to happen.
Happening. Because I know that we've only got less than 20 minutes left, and I think we're supposed to also try to talk about strategies as well with some of these principles. And so instead of trying to go and try to come up with strategies under all of these, you know, could we come up with some strategies under these 4 or 5 that we prioritize?
You know, Chip, I think that you're on point, because as I'm thinking about telehealth, as I'm thinking about scope of practice, as I'm thinking about trying to accomplish that, even that first one, maximize healthcare coverage, doing preventative care. Right now, we're one of 7 states in the country that has not moved forward with, working with the telehealth. And that's going to be a game changer if we can go ahead and work within the telehealth. We're doing it now because of COVID. But I can see that that's going to be something that's going to extend for years. Well, we may be looking at 2022 before COVID is over. And telehealth has really been good for behavior health, substance abuse, and for social isolation. So the telehealth, and of course, I've been talking about it for years, but the telehealth seems to be one of to me, a priority moving forward. And for us, especially in rural areas, and especially for the behavior health population, it's been used quite a bit. And a lot of physicians are going to, we can talk on the phone, but we can also email you or we can video you. And I think that's going to help with healthcare disparities. That's going to help with behavior health. That's going to help with even your preventative care and chronic illness.
I appreciate that, Representative Cunningham. The research is so clear on the behavioral health side that there is almost no difference in outcome when people get their mental health service through telehealth. The other thing that we have found with our folks when we started authorizing a lot more telehealth is that the no-show rate went down by 40%. If you're a single mother and you have to find childcare for your children and get on the bus and, get to your counselor once a week for an hour, I mean, that is a whole ordeal that is entirely avoided if you can just go into another room and do your visit and then come back. So I think that it is a major solution. It also helps with the inequity of access. We talked about parity as an insurance issue, and it certainly is, but the other concern with mental health access is that we have a mismatch of where the behavioral health folks live and where they need to work. Since we are in a free country, people can live where they want. I'm in Chapel Hill, and if I trip on the sidewalk, I will fall on a mental health counselor. There are too many in my town because they all trained at UNC and they don't want to leave. They like Franklin Street. And so, what we need to do is encourage these people to think openly about a real robust telehealth network and working in it. I really do think that is a solution. On the payer side where I work, I think the piece that we can really promote, and I'd like to speak with the Blue Cross gentleman, the flexibilities that the legislature and the executive have allowed us to have for telehealth, for behavioral health, and everything else, many of those have to continue. They have to continue. They just do.
Can I ask if we have a general definition of what exactly we talk about when we say expanding telehealth? Is it all these COVID era telehealth flexibilities for the private health insurance market? Because we don't have control over Medicare, and most of the Medicaid provisions have already been put into place permanently. So just I think it would be just the private market because Medicaid is already done, right? Or what?
Medicaid is close.
Do we all?
Yeah, I think my understanding is that with Medicaid, the E&M codes are going to continue, but maybe some of the more bizarre specialty stuff will probably sunset as it probably should. But the bulk of the outpatient will continue. But I agree with you that it's probably commercial that needs the focus.
Yeah.
Well, and let's not forget the 800,000 or so that are employed that are insured by state government also. State Employees Network, and that's controlled by the legislature too, not usually under the private market.
Okay, thanks, Bob.
And
That's a good
then,
point.
and then I think I've also heard, and I just want to make sure that that this group is talking about this when we talk about telehealth, the expanding broadband access. And then there are also some additional regulatory flexibilities around like out-of-state providers. And are we talking about that as well, or is it mostly just in the focus of private health plan reimbursement?
Are you talking about compacts?
So out-of-state providers being allowed to provide, through a compact or otherwise.
Yeah, I'm curious what Chip thinks about that. My concern is that if we start to add on additional things like scope issues or compacts, it can muddy the waters. And so if people are interested in that those be separate line items. I have safety concerns personally with compacts. I think I'm a strong proponent of the North Carolina Medical Board. I've worked with them for years. I trust them. I know several of them, and I just don't know the folks that license our clinicians in Alabama or South Carolina or somewhere else.
Well, this Representative Cunningham, and North Carolina nurses have been working on the compact for years. And, the scope of practice is where the issue is. But, as we start looking at primary care providers and looking at how many actually come out each year, how many actually remain in the rural area to practice, we can't push them fast enough to get them out. And that's why the compact, we did a psychological compact last cycle for psychiatrists and psychologists because we've been short. And then on substance abuse treatment out in the East is almost missing totally. So that was one, they were looking at options and ways to relieve some of that in those spaces, especially in the East. But the compacts and practicing at your highest scope of practice, I always go back to what the ACA was supposed to be doing, and even with the Medicaid expansion, was to allow individuals at the highest scope of their practice to practice. And that included your advanced nurses and physician's assistants and all types of individuals that fall up under those arenas. Those individuals can go out into the rural areas and practice, and it can be their home. And sometimes it's more attractive. They want to be out there. But because we don't practice at the highest scope of level, it also decreases the access to quality care. Because when I go to the doctor, sometimes I see the doctor, but most of the time I see the practitioner or the physician assistant. And so we've become, a country that's relying more on, the primary care. He might have 700. He can't see all 700 in a week. So they're overwhelmed, and we're not producing, doctors fast enough, in not just in North Carolina, but across the country.
I think the Nurse Compact has been a great example of how you can increase the speed at which someone can get licensed in the state. And that's what I think compacts should really be used for, is not for the compact to determine what the scope of practice is for anybody in any other state, but for them to gain access quickly to be able to provide services in North Carolina. The Interstate Medical Licensure Compact is one that does that as well, that we're going to be seeking for you to consider, Representative Cunningham, this year. Mm-hmm. And that would increase the speed by which the North Carolina Medical Board could license a physician that wants to practice in North Carolina, which is what we would need. We don't need it taking 6 months, right? If we can rely on trusted federation partners that have done background reviews and ensure the safety of that person. And if they are continuing to live in Richmond, Virginia, or Seattle, Washington, and can provide telemedicine visits, that's great, as long as they're still regulated by the North Carolina Medical Board, so that we have a way for the long arm of North Carolina to be able to reach out and enforce safety precautions to protect North Carolina citizens. I think the Nurse Compact and the psychological compact that you've adopted are both very much in line with that. There are other compacts that don't do that do tend to kind of go off into federalizing or nationalizing practitioners, and we have concerns about that because of Dr. McCann's, suggestion about that safety that we would just need to walk that line carefully.
But all nurses would fall up under the Board of Nursing in the regulatory in North Carolina. And so even the advanced nurse practices all still fall up under the guidance of the North Carolina Board of Nursing. So that, keeping it up under regulatory within the state is a good thing, definitely, even though they compact them and they can go in other states and work.
But to the earlier point, then the concern here is largely related to the desire to keep separate from the telehealth discussion is this idea of out-of-state providers, extending licensure to out-of-state providers.
Yeah. I mean, I think the point is that, telehealth reimbursement, telehealth, recognizing the utility of telehealth is separate from increasing broadband activity and increasing the possibility of out-of-state providers providing services. They're related, but they're still unique issues that, in order for us to address all the nuances of each, they probably need to be
You're saying separate
listed.
them, Chip?
Yeah.
Separate them.
Yeah. And we can always talk about how one supports the other, but they're three distinct sets of decisions that need to be made.
Mm-hmm. Yeah, I can agree with that because, telehealth is at the top and you got the three other decisions that come below them.
So just as a time check, we have about 7 minutes left. And perhaps we can save the last 3 or 4 minutes just to have an opportunity to say, what kind of, or how can members of the council carry some of this work forward after today's meeting, if you have any thoughts around that. So maybe we spend another three-ish minutes on the principles, and then we can kind of shift to how do we want to continue this work going forward.
Can you scroll down?
Sure.
That's the last of it?
Mm-hmm.
Okay. Can you scroll back up?
Yes. So at the top here, the principles that fall are the kind of points that fall under maximizing healthcare coverage.
Okay. One thing, Chip, that we really, and I guess wasn't thinking about it, but our focus hasn't been on prevention. If we're not doing preventative care, can you go back up?
Mm-hmm.
We can do all the healthcare in the world, but if we're not doing preventative care, we're still gonna be in a quagmire at the end. Where is prevention?
I wonder if that could be included under that comprehensive definition.
It's down at the bottom.
It's at the bottom?
Yeah, right now it falls under this additional considerations.
So I think the one thing in listening to the previous discussion, I was trying to keep quiet, but I can't. Let's don't be recommending, or this is for Representative Cunningham, particularly since you're in the legislature. Let's recommend it. Yeah, well, just let's don't recommend things or do anything that's going to potentially undermine the primary health care in rural communities, because I've been trying to promote this workforce development with incentive programs, loan repayment things and things like that, because we really haven't, I don't have all the statistics, but the Shep Center can tell you that we actually produce plenty of healthcare providers, but they don't go where they're needed to go. So we need to incentivize them to go. We have a hard time here, and we're a very well-respected primary care practice, but I can't retire because we have a hard time getting someone to come here, whether it's a nurse practitioner, PA, or family physician or pediatrician. They have a hard time. They'll go to Raleigh. If we were 30 minutes closer to Raleigh or Wilmington or somewhere else, it'd be easy. But, and you're exactly right. Primary care, that's where the preventative care is done. And if you do that, that's going to lower that total cost of care. And that's going to, it's been shown to do that and proven to do that. So we need to work on that workforce distribution as much as anything. And, you know, I've gone back to explain, one reason I'm in Clinton as opposed to Cary, where I interviewed, was because I got, from the Office of Rural Health, I got money to go to med school while I was in med school. And what I had to do was pay it back by going to a rural or underserved area in North Carolina for a year that I got the money.
I want to understand what you just said. Cannot undermine primary care services. I'm trying to understand what your intent was when you said that.
Yeah, sure. I think my concern that I've seen with the Medicare Advantage and some of the private people, I think telehealth has got in my experience, telehealth has got a place in my practice now. You know, we hadn't been using that, but it's going to have a place. If you open up telehealth too much to out of state and things like that, people are going to, without giving me the opportunity or infrastructure or the opportunity to do that, supporting people like myself to do that, you're going to have the big box people calling people from out of state and trying to do their primary care when they don't know them. And I've seen that a lot already in the Medicare Advantage sphere. And so I worry about that becoming and that undermines. I mean, I can give you some anecdotal things that have happened to patients of ours that, didn't do the right thing. And so, whereas if they'd have just come to see me, and we're open every day and access every day.
Well, let me say this. It is not my intent to undermine the rule in the telehealth space. It's not. And I would not make any recommendations of anything that would hurt any part of North Carolina. But let me be clear. You may have a primary care physician in Clinton, and you may not have a psychologist in Clinton, but you have a lot of behavior health issues. So I think the regulatory, as we go forward, we will have to be careful. But I think this is a change that is going to take place whether we like it or not, because COVID is going to be around a whole nother year. And we just in an unpredictable space. But it's going to take time because it's not a lot of broadband in places that have the major need of even doing telehealth. And you got people still staying at home right now, not going out, homebound, that need to have some type of service, health service, and not have to go out. So I think, it's a change on the horizon because of the COVID, but I think it's going to be around. We're just going to have to manage it and regulate it according to what North Carolina wants to see with it.
I appreciate I appreciate your caution, Dr. Newton. That makes a lot of sense.
Mm-hmm.
And I also agree with the behavioral health aspect of telehealth, because I think I mentioned last time that we're getting ready to participate in a project to that effect, to bring behavioral health directly to my office and the patients in my office, which is that's where it needs to go.
Mm-hmm.
Thank you.
Well, thank you all for a good discussion. I hope I've reflected those comments here. Chip, I emailed these to you just so you have a copy, but I'll be sharing my screen when we go back. Any final thoughts around, we have 25 seconds. So anything in terms of is this important to continue these discussions after the meeting today?
I
Yeah.
I think we still got a lot to discuss. We should.
But folks are generally comfortable with the principles as written.
I am.
All right,
Agreed.
thank you.